We're just going to let a few more people come in, and then we'll go ahead and get started. All right. Well, welcome to everyone watching both in the US and abroad. We're happy to have you here. I'm Dr. Alan Siegel, co-founder and director for Social Prescribing USA, and a longtime practicing family physician and social prescriber. Today, we brought together experts from the US, a leader in the student movement, which started at Harvard, a leader from the UK, who have been driving this movement, and a leader from Canada who has been working with a special population, all to speak to you about social prescribing. We also have a few participants in social prescribing programs to talk about their experience. But first, we'd like to know who you are. Please put in the chat your name and where you are from. So social prescribing allows doctors such as me to be more able to address our patients' needs using all the tools in the toolbox, rather than the very limited ones that we have now. Social prescribing refers to doctors, health professionals, or really anyone prescribing non-medical interventions. So usually some combination of the arts, nature, service or volunteerism, belonging, movement. One of the major areas which is now being appreciated, especially with the great work of our Surgeon General, Vivek Murthy, is the problem of loneliness and social isolation. And these are areas that we're really ill-equipped to help and fall into an area called social health. So plenty of studies now show social health to be as important as mental health and physical health. And we need ways to address these problems. Our standard medical care really falls down for that. While it looks different all over the world, many programs address social determinants of health, including core needs such as housing and job skills, and also social connection. These aspects of health determine actually 80% of one's health, and we're addressing them in early stages in the US. In at least 31 countries around the world, and in some of them widespread, such as the UK, and we'll get to hear about that soon, patients are identified suffering with mental health, loneliness, social isolation, chronic disease, diabetes, and needing help with social determinants. And social prescribing offers alternatives to address the full holistic needs of our patients. While aspects of this work have been done for decades, Social Prescribing USA is working to make this widespread in the US with our goal of 2035. We're building networks, including our new health professional champions, and our community of practice with implementers across the US, over 200 of them who helped put together this webinar. We're gathering articles and tools to make them available to all of you so that you can become part of our advocates and use that information to be able to push your system or push your government to be able to change things. And we're connecting with stakeholders to bring the many partners in these efforts together so that we can move this work forward and make it available to everyone. Last week, I had the pleasure of attending the first social prescribing national conference in North America, which was in Canada, put on by the Canadian Institute for Social Prescribing. We were able to compare and contrast how does social prescribing look in several different countries around the globe and see a wide showcase of how it's being implemented in Canada, the UK, and Australia. Social Prescribing USA is working to follow this up by bringing the first US conference here in the next 12 to 16 months. Here in the US, we have at least 40 pilots trying different ways of social prescribing. Most of them are being studied now and should have results by the end of the year. We're excited about that. We need this data to really show how these programs are being effective here in the United States. We have models that include healthcare insurers paying for social prescribing to address their high utilizers, who are people who visit the ER and clinics and get hospitalized often. We have other models that use grants that are grant funded to bring these tools to the aging patients who are lonely at high rates. So different people are trying different things. We have other programs in large medical centers where social prescribing is being used for very specific problems. That includes the geriatrics population at Cleveland Clinic, those with high blood pressure at Harvard, and the undergraduate wellness at Stanford. We also have a business model from Art Pharmacy, who has partnered with entities such as the Massachusetts Cultural Council to bring the arts as intervention to those who need it in our state. So as you can see, a lot of people are trying a lot of different things, and that's probably what we're going to need to do in the United States. So let's get deeper into this topic together, learn from what's been successful abroad and in the US, and picture how this can look when fully integrated into the complex US healthcare system. Then we can all start working to make that dream happen here. We hope you come out of the webinar excited about having social prescribing be available to you and to everyone, and wanting to join this movement to help make it happen.
Hi, everyone. It's wonderful to see so many people in the room already. My name is Ivory Rose. I am a white woman with brown hair, wearing glasses and red lipstick. And I am an occupational therapist and poet located in Glendale, California. I'm also the lead for healthcare engagement and strategic initiatives at Social Prescribing USA, and will be your moderator for today's webinar. And before we begin, I just want to take a moment to acknowledge the Tongva Nation, on whose land the city of Glendale, where I'm located, rests today. I hold respect and gratitude for the Tongva people, and I'm reminded of our responsibility to the planet and to one another. So let's take a moment in our own way to honor the indigenous communities of past and present, on whose land we are all joining from today. And there is a slide with a photograph of some beautiful orange flowers here that are often seen outside of Los Angeles area. We also would like to acknowledge that many communities have practiced social prescribing and its principles for hundreds of years. We at Social Prescribing USA acknowledge that social prescribing should not attempt to reinvent the wheel, but rather honor that it builds upon indigenous and holistic conceptualizations of health. So in today's introductory webinar, you will gain an overview of social prescribing, what success has looked like in other countries, as Dr. Allen mentioned, and hear testimonials and perspectives from providers, organizers, and students contributing to the movement. You'll also learn how to join the movement and take action today. So who are our speakers? The speakers on our panel are Dr. Allen Siegel, who you just heard welcome and introduction from, Dr. Bogdan Giurca, Hathor-Ra Adwoa, and Rachel Chen. Each speaker will present for about 10 minutes, and then the last 15 minutes will be the Q&A section. We will also share with you 2 brief testimonial videos from participants of social prescribing programs right here in the US. And as a reminder for the audience, if you have any questions for any of our speakers, please type them in the chat box and include the name of the speaker who your question is for. So they can either answer them immediately in the chat box if able, or our team can also track them and address them at the end during the Q&A section. And then we'll conclude after our programming with some brief announcements. Now I would like to introduce our first panelist, Dr. Allen Siegel. Dr. Siegel is co-founder and director for Social Prescribing USA, concentrating on strategy, communication, and development of the community of practice, and building a network of health professional champions. In 2023, he completed a grant for the California Healthcare Foundation to create a model for social prescribing in a county health system. He worked within Bay Area's Contra Costa Health for the last 25 years, and most recently, he is now a family physician at Kaiser Oakland and plans to initiate and spread social prescribing at Kaiser. He was a founding board member of NOAA, the National Organization for Arts and Health, where he concentrated on bringing the arts to healthcare workers and building regional networks. Thank you, Allen, for sharing your knowledge with us today.
Thank you very much, Ivory. So, as she mentioned, I've practiced family medicine for the last 27 years, mostly with the underserved. It's been striking to me for much of that time how much medical care we offer in certain areas like heart disease and diabetes and lots of other things, but how little we offer in other areas that are critical and are now being appreciated, like social connection. And with some exceptions, how little the health providers are actually connected to the community, because the community is where most healing happens. And by most, we know that 80% of people's healing happens in the community and based on their social determinants. So we'll talk about that in a bit. Before it was called social prescribing, I've been a social prescriber for most of my time in practice, primarily in the arts, running an arts and health program for the last 13 years at Contra Costa Health, as she mentioned. So why should social prescribing matter to you? For all the time I've worked in arts and health, it has remained a niche. available to only a handful of patients. I've also been a nature prescriber and brought kids with pediatric obesity and their families to regional parks with education and movement programs, expressive arts, and live music. I helped build a program to identify and support social determinants. I've also seen the power of the community as I've led group visits for over a decade. So if we can adopt social prescribing and build it into our healthcare systems, we can make arts and culture, connecting people and nature, and community as medicine available to everyone in the United States. So today I want to talk a little bit about my journey of how I got here, state of our healthcare system, and about social prescribing and Social Prescribing USA. So change is hard, and most people won't do it, even if their life depends on it. What does it really take to change? So in my daily research, Monday through Friday, patient visit after patient visit, I've calculated that I've done about 50,000 patient visits. People really have to hit bottom and crash before they're motivated to actually change. And this is the bright side. We're actually at that moment. And we could keep doing what we're doing and pretend it will get better, or we could do something different. You see, COVID made things much worse. Slide, please. We're now in a mental health crisis. About a fifth of people have anxiety, a tenth of people are depressed, a chunk of people are PTSD. We're in a loneliness crisis. About a half of Americans say that they're lonely. And in some populations, such as youth, it's actually up to 80%. And these risks are real. Many of you have probably heard about the 3/4 pack of cigarettes, and not sure exactly what that means, but that means you have a third higher chance of having a heart attack or stroke or death by 20%. We have a healthcare worker crisis. About a fifth of doctors have left already in clinical medicine. About a quarter more are planning to leave in the next 2 years. We have an aging crisis. By 2030, the baby boomers will be more than 65 years old, and older Americans will make up a fifth of the population. Many of those people need family and friends and caretakers, and most stop working and need more healthcare. And in 2020, that cost was about $1.2 trillion. I don't know what numbers like that mean, but if you compare it to our whole GDP, it was only $28 trillion. And one more that's not really talked about much, but that we probably should take seriously, is decreased membership in community groups. So Robert Putnam, a social psychologist out of Harvard, called it civic capital, wrote a book 20 years ago, and it's still getting worse. But we have about a decreased membership, about a quarter to a half of membership in civic society for the last 2 to 3 decades. And when he studied that over time, that usually does not bode well. So next slide. So what if I could prescribe something that could improve your anxiety and depression, your PTSD, your diabetes, heart disease, that had virtually no side effects, much cheaper than anything I'm doing now, actually improve your loneliness, feel more connected to others? What is that magic prescription? I'll give you a hint. It's not another cholesterol medication. So I want to go back first to where my fire was lit about this. I got seriously depressed during my 3rd year of residency. I got on meds pretty quickly. I got therapy, really our best therapy, our best treatment that we have to offer in this country. But despite my doctor and my better efforts, I spent about 6 months at the lowest point in my life. I lost all confidence in being a doctor. I finished residency. I lost the healthy connections to my fellow residents, to my faculty. And I did heal over time. I essentially did my own social prescribing, moved across the country, and went outdoors. I got into triathlons. I started playing music again. So I was able to heal. But as a healthcare system, is this really the best that we can do? You see, I worked with patients for the last 25 years who didn't have many choices, that we were a system of last resort, mostly with Medicaid patients. But in that environment, we were able to find healing through the arts. One of the examples that I loved was a beautiful weekend workshop program called Stress Reduction Through the Arts, where we would engage healing and support through visual arts. And by creating and sharing their arts with others, people opened up in a way that I've just never seen. They came from a very vulnerable place. And while I've done a large amount of groups over my work, it was some of the most intense sharing of traumas that I've ever seen. So I saw what art was doing for patients and staff and got involved nationally, as Ivory mentioned, in trying to bring the work to healthcare workers to prevent burnout during COVID. It seemed like an obvious problem that we needed to work on. So I learned more about social prescribing and realized that I've been a social prescriber for the last 2 decades. I was doing what I thought felt right with arts and nature, with plenty of evidence to lean on, and I knew that this was what I wanted to dedicate my life to. And that's become just clearer since then. One perk is that I can still work on the healthcare worker issue because we can have programs for healthcare workers. As a prescriber, I feel much better at prescribing arts and nature, things that I know are healthy interventions for my patients versus things that are much more mixed interventions. There's more than 3,000 studies showing that arts interventions help anxiety, depression, and all these problems that we're talking about. And some of this data is actually much stronger than some of the medications that I prescribe every day. So I connected with a few others that were making noise around the social prescribing thing in the United States, and we formed a nonprofit called Social Prescribing USA. Next slide, please. So what is this thing, social prescribing, and how can it be one of the answers to a healthcare system that spends a ridiculous amount of money and doesn't get back the results for that? We spend twice as much as other wealthy countries, and some of our outcomes are actually much worse. So social prescribing allows the doctor or other health professional, or really anyone, to identify people with anxiety, depression, chronic disease, and they refer to this intermediary. You can see it's called a link worker in the UK, but it could be a community health worker here or a social worker, someone trained to ask the question, what matters to you? Rather than our usual, what's the matter with you? Next slide, please. So what matters to you? It's that simple. And we really don't ask that question nearly enough. We assume that we know what matters to people when we really don't. What matters to you? It's patient-centered as we are striving to be. So an intermediary finds out what brings you joy, where's your happy place, what works for you, and depending on the plan that you make together, connect that person with community organizations who provide art, nature, movement, service, and belonging, community groups. They often address social determinants, and these intermediaries help break down barriers that you might need help with transportation or childcare or need a caretaker to come with you. So social prescribing, as we will hear, has expanded to over 31 countries, all at different stages and mostly in countries with a socialized healthcare system. In the UK, you can walk into any clinic and get referred. And we have about 40 pilots going on here, growing all the time. And social prescribing is going to happen here. Our goal is to be widespread by 2035. But it's not an easy backdrop here with over 900 healthcare systems and only about a third of our care coming through the government with Medicare and Medicaid. So let's go back real quick in the next slide, please, to a multitude of problems that we're facing and why we're now at a time when we're desperate enough to change healthcare. We talked about our mental health crisis. Social prescribing can help this with arts and nature. The evidence is strong, about 40 years in the arts. We're in a loneliness crisis. It's a big driver for social prescribing. In the UK, for example, and Japan, they have ministers of loneliness to build social prescribing programs. Our healthcare worker crisis, social prescribing can help burnout, both in doing the prescriptions, doctors can feel good about what they're doing, and also having a social prescribing program for the healthcare workers. Civic engagement, if this is done well, people will be engaged in others doing the things they love doing. Our aging crisis, social prescribing gives you healthy behaviors, addresses social isolation, and includes the caretakers, a group we really need to be paying attention to. So we could have 10 million more people volunteering, another 10 million more people going out to nature, appreciating the need to work on climate change. What about 10 million more people expressing themselves through creativity in the arts? And another 100,000 doctors prescribing the arts, nature, belonging, service. Clearly, this is the right thing to do. I explain it to people and people are like, oh yeah, obviously we should do that. But it's also been good in studies, a good return on investment in other countries. We don't have that data here in the United States, but in the UK to Canada to Australia, they've shown ROIs of somewhere between $3 and $7, which is amazing. Next slide, please. So this is an important moment and when we can actually make this movement happen. And I want you to be a part of it. I want you to have the experience of having your doctor ask you to do things that get you excited and to make you feel better with your friends and your family and maybe meet new people. Maybe our doctors, instead of just telling you to eat better and exercise more and I'll see you in 6 months, could be prescribing a dance class or a pottery group. And I want you to be part of the movement. Maybe that's just learning about it and telling others about it. You can do a lot of that on our website. You can sign up for our newsletter at socialprescribingusa.com, or get more involved in our community of practice, a growing group of implementers from across the country working to make this happen. We have a new health professional social prescribing champion group, and you can start your own local group and we can help you. But if we all start asking these questions and start making some noise, we can make this a norm in the United States and start really working on our problems. We can become more socially engaged and help others do the same. We can become our own social prescribers and be a real example for those around us. So the time has come, and I want you to do more of the things that you love and the things that keep you well. That is my social prescription to you today.
Wonderful. Thank you so much, Alan. You know, I think it's really powerful when people hear testimony from those in healthcare that say something needs to change in healthcare. And I can also relate to that as a practicing occupational therapist. So thank you, Alan, for that very helpful presentation. And I'm excited to introduce our next speaker. I would like to welcome Dr. Bogdan Giurca, who's a British physician currently working as the clinical lead and global director of the National Academy for Social Prescribing. His work has influenced national and international healthcare policy and has been instrumental to spreading and scaling social prescribing globally by hosting delegations and ministerial visits from over 30 countries, as well as implementing social prescribing in the core curricula of major universities and medical schools within the UK. As an honorary lecturer, Bogdan currently lectures at University College London as part of the Masters of Applied Science on Creative Health. In addition, he holds teaching roles at Imperial College London, Harvard Global Health Institute, and has been recently named top 100 most influential people in health in the UK. That's a big title. Thank you so much, Dr. Bogdan, and we're excited to have you here today.
Thank you so very much, and good evening from London to everybody. It's always embarrassing when you hear that whole biography there. I think, but it's so nice to be here with you, and I must congratulate US colleagues and Canadian colleagues for such wonderful work and advancing this field forward, and of course the Canadian colleagues for their brilliant international conference, which I missed. I wasn't in person at, but I hope to be in person at the next US conference. I'm Bogdan. I work in emergency medicine by background, but of course, as Ivory Rose was just saying, I work at the National Academy for Social Prescribing. Next slide, please. And what I'd like to start with is just hammer in some of the points that Dr. Alan Siegel mentioned earlier, which from my perspective is the way we've been doing healthcare for a while now is we haven't been looking at health as we should have. We see it from a system perspective. We see it as healthcare, which actually not even healthcare, but rather sick care. So sadly, what I see that disappoints me every single day in the emergency room is a lot of individuals that we fail. We've been leading this sick care model where we operate a revolving door model where one patient comes in and the other goes out, and we simply focus on what's broken already. We try and hammer and fix things. We wear white coats and we have pens here and we call ourselves doctors, and people come to us because we are the experts, but we have forgotten the power of local communities and local voluntary groups. And I'm very pleased to see such strong representation from occupational therapists, voluntary sector today, healthcare professionals, because occupational therapists have actually been doing social prescribing for so long. And so, as you said earlier, it's not a new idea. It's been with us for many years, but I think we are starting to understand its benefits more through evidence and research. These are just some very quick statistics from England alone. I am sure Canada is facing very similar issues, and US as well is facing very similar issues, as is the most of the rest of the world as well. So in England alone, 1 in 5 appointments, so 20% of all of our appointments are for pure social reasons. So we're talking about loneliness, isolation, debt, finance issues. They would come to me in the emergency room with what looks like a medical presentation, but in fact, it may have been an anxiety attack. It may have been palpitations caused by stress or anxiety. And this is not even tackling the appointments that present for mental health reasons. If we add those into the mix, it goes above 50% of what we see in England in the emergency department. 1 in 4 emergency admissions, so 25% of all admissions in England actually are due to medication side effects. And in fact, there was a recent report in England by the Chief Pharmacy Officer at NHS England, our healthcare system, that showed that 15% of all drugs prescribed not only are unnecessary, but are also causing harm and should have not been prescribed in the first place. But as clinicians, as always, people come to us for answers. What's easy for us to do is to give them another pill for their illness, send them sadly back home to what made them sick in the first place. And then we put them again through the revolving door, which needs to, of course, stop. And as you probably have in the US as well, 6 out of 10 people now suffer from at least one chronic condition, and 4 out of 10 people have 2 or more chronic conditions. So the sick care model is unsustainable. And as Alan said earlier, we need to start looking at health from a non-system perspective more than before. Slide, please. Thank you. In 2019 in England, our government decided to shift focus from the acute services to move away from the sick care model, to move away from health that is being delivered within the hospitals to moving to community and out of hospital care, to look more at the idea that one size does not fit all, to look at personalized care, person-centered care, putting the patient at the center of the equation, and to redesign the way we deliver healthcare in England, and a bigger focus on population health. Next slide, please. And earlier, with a year before, the Prime Minister at the time, Theresa May, announced a loneliness strategy. And this is where social prescribing started trending. As you've all mentioned, social prescribing has been a concept that's been with us for many, many years. However, in England, it started gaining a lot of interest from 2018 to 2019, when a lot of pilots started showing evidence. And it was a key part of the government's loneliness strategy. Slide, please. And from there, it was the first country in the world to implement social prescribing at a national policy level. So in 2019, there was an investment of around £300 million from the government into officializing social prescribing as a model in England, and making it a core part of what we do as clinicians in the UK. Alan's already spoken a bit about what social prescribing is. I just want to give you another takeaway from my perspective, is that there's a global definition that we all worked in together with Alan and other international partners that always looks at it in three dimensions. You don't need to have the doctor, actually. You only need 3 things. You need the identifier, so the person that identifies the person with the need, and there must be a need, of course, be it loneliness. It could also be a neighbor of that person. It might be a taxi driver. It may be a hairdresser. It may be the occupational therapist. It may well be the doctor in the emergency department, but it doesn't have to be that. So there's an identifier of the problem, of the need. Then there's the connector. In England, we've developed something called the link worker, the social prescribing link worker, that connects and acts as the cohesion between the healthcare system and the community. But again, it does not have to be that link worker. Many countries around the world are actually using the social worker upskilled to be that connector. But quite often, the doctor is that connector as well, if time permits. In England, time does not permit. With the 10-minute appointments, we have to rush very quickly through our patients, very sadly. And then the third element, so we talked about the identifier of the problem, the connector, and then the third is the activity itself. And the voluntary sector, of course, we turn our heads to that. But of course, you need proper investment, proper funding into the voluntary sector, so that the voluntary sector doesn't actually clean up the mess created by the healthcare system, very importantly. Next slide, please. And in terms of the National Academy for Social Prescribing, it was set up by the Minister of Health at the time in 2019. So the idea was we were funded with government funding to support the delivery of social prescribing across England. Note how I'm not saying the UK, because of course, as you know, the UK means also Scotland and Wales and Northern Ireland. And therefore, we've only been supporting the development in England. And there is different stages of social prescribing prescribing in all of the other areas across the UK. What's amazing about the National Academy for Social Prescribing, from my perspective, is the sheer breadth of employees and staff members in our team representing different sectors. So we have a national lead for sports, we have a national lead for arts, we have a national lead for nature, we have a national lead for heritage, and all of them are seconded from those governmental bodies who are representing this sphere. Therefore, health is no longer part of healthcare and the Department of Health, but it's being democratized. It's being placed in the middle, whereby all of the other departments, Department of Culture and Arts, the Department of Work and Pensions, the Department of Heritage and History and Museums across the UK, they can all support through a stadium for the elderly. For example, Manchester United, we've had elderly individuals play sports using the space. Some offers of support quite often don't come with funding, they simply come with a space, such as a museum or a free ticket at a gallery, and so on and so forth. It's been that idea of democratizing health in its truest sense, and getting together the researchers and the evidence for it, of course, as well as flying the flag, as Alan was saying, across the world and meeting colleagues from over 30 countries across the world. Next slide, please. And I can see Ivory Rose has appeared on my screen, so I'm going to rush quite quickly through the final slides in here. Just to give you some updates on what we've achieved in England to date, we have recruited over 3,600 social prescribing link workers. So every single family physician in England has access to a social prescribing link worker, meaning that any patient across the UK requesting social prescribing would have access to it. So it's been made universal. It's been so successful that sadly now we have 6-week waiting times. So we need to quickly increase that number of social prescribers and do it fast. Over 2.7 million patient referrals, more than £500 million of investment, and there's a commitment from the government to triple those numbers in the next 15 years. Next slide, please. In terms of the impact, I think this is very important, but you can read further on our website and in terms of the evidence reports that we created. All the studies that we've done so far in England, but also across internationally, show a 20 to 40% reduction in family physician appointments where social prescribing is being used, and a 15 to 25% reduction in emergency department admissions, unplanned hospital care admissions due to social prescribing. If I had a pill and I went out with it and I said that it does those things, I promise, I'm sure I would get a Nobel Prize for it. But because this social prescribing is not a pill, this hasn't happened yet. Anyway, next slide, please. And of course, we have several future opportunities, and we're working with various departments in the government, with the Department of Work and Pension, and there's various investments from the other spheres of nature and arts, and it's also been made a core part of what we call the major health conditions. So all of the big conditions, musculoskeletal problems, dementia, and so on, have been included in this. Social prescribing has been made a core part of that. Next slide, please. I'm nearing the end, I promise. 20% of our individuals in the general public now understand what social prescribing is, which, believe me, I know it doesn't sound much, but it's a huge win because it means people can get the support that they require. Next slide, please. And I think that the most important element has been the evidence. Without the evidence, we would have not been able to convince the government. We would have not been able to convince quite big-headed clinicians like myself who think they know best and who always give and prescribe pills for unnecessary social situations. And so you can find all of this on the website, regardless of the topic that you're interested in, from physical activity to children and young people to the economic impact. Please go and have a look at this, and we will put this in the chat as well, and you can have it as a takeaway. Next slide, please. And what's been fascinating to see is, of course, the global picture, which it's been a bit of a baby project for me. I've traveled to over 30 countries to support individuals, and we've received ministers of health from all over the world to find out how they can develop their own model. Alan, Dan, and of course the team at Social Prescribing USA have done an incredible work so far. This map is already out of date, and we will renew it very soon with newer and stronger partnerships as well. Next slide, please. And wherever you go across the world, the social prescribing link worker, the person who does the connection, may wear different names and different hats. In Japan, it may be the Sheikatsushien, which is their community worker. In India is the ASHA worker. In the UK, as I said, is the link worker. In Canada, it may be the community connector. In the US is the health lead advocate. Whatever the name is, they are the ones facilitating that relationship between the community and healthcare. Next slide, please. And I'm reaching the end, I promise now. And if you'd like to hear more about international projects, I wish I had 3 hours to take you through all of them, but I've spoken enough. So please grab this report. It's a free report that you'll find on the National Academy for Social Prescribing website. We developed this in partnership with Alan and international partners around the world and the WHO, and it contains 32 case studies of countries from around the world who are developing social prescribing as a model. Next slide, please. And that is it, you'll be pleased to hear. I've spoken enough. I hope that was interesting. You have my email, and please, I welcome any questions that you may have. Thank you so much for having me.
Thank you so much, Dr. Bogdan. What a wonderful presentation. And you really set the tone for, talking about how doctors can completely believe in the power of social prescribing, but don't necessarily have the time to spend with a patient, and how important that role is of that link worker or community connector, or the various other titles. So in a moment, after we hear a patient perspective, we will have the honor of hearing from someone who's actually in that connector role. But first, we're going to hear a brief testimonial video of a patient. So this is Mr. Thomas, a patient over 60 at Sanitas Medical Center in Palm Beach, Florida. When he was screened by his primary care physician, it was found that he was lonely, and he therefore was connected to the community health worker at the center so she could help him connect to other people in his community. He joined the Communities of Well-Being, which is a strategy that connects patients that need support, and there he started to make new friends. This testimonial was taken after he had participated in the program, and he really wanted to share with you how connecting with others made him aware of how loneliness was taking him down a dangerous road with alcohol. And if that hadn't been identified by the center, and if he had not received a social prescription to this program, he would have had a different story. So we'll hear from him now. We can't hear the audio.
Can you hear any of it? It's been recorded at a low volume.
No.
You don't hear any of it? 1 second.
And the illness took me. Right. So it woke me up to a condition I was not aware of. I was lost in my own condition or my life situation. And so I got ill, and the illness took me to the program. The program made me see the avenues out of it. Because when you're in a condition, you're lost. You're not aware you're in the condition. The sickness woke me up to make me aware that I was in a condition I wasn't aware of. And the program like shone the light on how you can get out of it. And I was, for example, I was drinking too much, slowly drinking too much without realizing it. And I was realizing, especially after this session, how I was being drafted into being an alcoholic. I wouldn't have realized it, and I guess that's how people become ill or become alcoholics or diabetes or anything. Your condition draws you into it without your awareness. And in other words, now in seeing, when you're on a path, you're able to see where the path is taking you to. So I'm able now to like see, wow, that's where you were going. I was going to become an alcoholic, and that was going to make me diabetic, and so on and so on and so on and so on. So it lighted a path for me to see where I was and where I need to go.
Okay, thank you, Mr. Thomas.
Right. So
Okay, thank you. Now I'm excited to introduce our next speaker, Hathor-Ra. I have had the pleasure of seeing her speak both in person and on the virtual Canadian Social Prescribing Conference for the past 2 years. And I can tell you, you're all in for a treat. She's a wonderful speaker. Previously named Sabrina Morrison, Hathor-Ra started her journey over 20 years ago in human services and mental health, now offering her contagious, zesty personality while dedicating her life to spiritual healing as a spiritual doula and as a mental health national instructor. Hathor-Ra has served as a case manager for municipal and provincial governments, a support counselor for Corrections Ontario, a nurse assistant, a certified mental health first aid instructor, and a mental health advocate. Presently working for TAIBU Community Health Center as a Black-focused social prescribing navigator, Hathor-Ra continues to support health equity and community healing from an African-centered approach while dismantling anti-Black racism within the various systems in Canada. Thank you, Hathor-Ra, for joining us today, and congratulations to you and others at TAIBU for being amongst the recipients of the 2024 Canadian Social Prescribing Innovation Award. Thank you.
Thank you, beloved. Thank you. Greetings, everyone. Ivory, it's weird to hear these things being spoken about you because you just do the work. My name is Hathor-Ra Adwoa. I am from TAIBU Community Health Center, and I am one of the navigators from Black Focused Social Prescribing. And basically, I just tell all our clients and community, it's a non-clinical way to deal with clinical needs that is rooted in African principles that makes it safe for Black and Brown bodies. I want to acknowledge the land that we are on here in Toronto, Ontario, Little Turtle Island, and our various Indigenous brothers and sisters. I want to acknowledge that those who came before us, the grandmothers and the grandfathers. A part of this land acknowledgement from an African-centered way is also pouring libation. So I'm using spring water, and I have a plant in my hand, and I'm going to be pouring water. And this is our way, from an African-centered way, to also acknowledge the land that we're on, acknowledge those who came before us, those who established the richness of the beautiful energies and the waters and the rivers that we are benefiting from as settlers here. So as we pour libation, we call the names of those who came before us so that we can be here and speak as women or as men and freely here in Canada, and also in the US and any other countries that are here on our Zoom call. So I'm just gonna pour. As I pour, I call Sojourner Truth. I call my grandmother, Vione McLennan, my grandfather, we call him Bretta T, my great-grandmother, Susan Seaton, who died at 104, my also great-great-grandfather from Papua New Guinea, my grandfather, Pops, we call him Pops, my grandmother, Mary, and all of those who came before us. I pour in acknowledgement of them in this plant, and I'm just gonna put it back on the side here. Next slide, please. So a part of TAIBU, we've existed for over 16 years. This year we celebrated 16 years. Black Focused Social Prescribing is only one of many programs. Our programs so far in the 1 year, we just started in 2022 and ending in 2023. We started the implementation at 2022. So that was the end of 2022. So from January 2023 to December 2023, we saw about 72 Black focused social prescribing clients specifically. So one of our gentlemen, it's similar in Canada, where the service provider sees the need and they make an internal referral in our system. Now, as I said, Black focused social prescribing is one, but we've been doing this for aeons, whether it was dancing, drumming, singing, humming. We've been doing all of these various ways of medicine to look at our spiritual health, our mental health, our emotional health, or even our physical health. So with Black focused social prescribing, now we can call it a name. Now we can collect data. So some of the referrals to this program in 1 year alone were internal referrals, about 59 internal referrals and about 30 external. And then we developed 2 programs out of that, which came from the community. Next slide, please. So some of the demographics just within Black focused social prescribing is mostly Black identified Caribbeans. So that's about 50%. So half of our population identify as Black from the Caribbean. We have others that identify as Black African, which is about 18%. We even have a couple of South Asians that were referred to us. We have 2% that identify as white and 20% identify as just being just Black. So our demographics is, I would say 50% as you see here, but a little bit more because we'll get our new stats for 2024 next year, who identifies Black, Caribbean, or African. Next slide, please. The origin story. So TAIBU, like I said, has been here for 16 years. We had to advocate for health equity just for health care, just to get a prescription, the right prescription, just to be heard in a Black body. So TAIBU did a lot of that groundwork over 16 years ago, where now we have a specific center that gets special dollars to serve the Black community in Malvern, Scarborough, which is in Ontario. Now, similar story happened for our program for Black focused social prescribing. We were approached years ago, about 2017, about social prescription, but it wasn't the right time to have an African lens that would have created a space for equity. And that was really important so that we can have programs that speaks to African Caribbean foods and dance and culture, because it's in our DNA, and our DNA has to resonate with the programs or else it won't work. So we came together and decided to have about 4 organizations to come together to advocate for this health equity. So in 2017, we said, you know what, this is not for us. After George Floyd, we were approached again, and now we were able to pilot this beautiful project, like I said, with the 4 sites. So the origin story actually started with health equity advocacy through TAIBU, and then we partnered with the other agencies. Next slide, please. So some of the agencies are Rexdale Community Health Center, Somerset West, which is in Ottawa, Black Creek, which is in the west side, and we also partnered with Alliance. We also have Black focused evaluators, which is great, so that they have that equity lens. So we have social determinants of health. We also have social determinants of equity, which is very, very important when articulating our stories. Our funder is Balsam Foundation, which they're great, and I want to thank them. Hopefully we get to continue the partnership in our 3rd, 4th, and 5th year. So those are our partners. We work collectively. We work from an African-centered principle, which we're going to talk about in a moment. Next slide, please. So one of our things is that Black-focused social prescribing is an equitable vehicle driving socio-demographic change for Black identified communities. So this is something that we all have a similar view, that this is a movement for equity. This is not a program. This is not a pilot project. This is a movement for Black identified communities and Black identified bodies for the changes in the healthcare system. Next slide, please. Like I mentioned before, our project is steeped in 7 African principles, which are the 7 Kwanzaa principles. So basically, I like to say that if you're not good, I'm not good. and the community is as healthy as the individual, and the individual is as healthy as the community. So to make sure that the community is healthy and the individual is healthy, we need some principles to live by. So the main principle that we all work with all 4 sites is UJIMA, which is collective work and respect. So this is one of the major principles that we use in our project to make sure that we are all aligned. And we use these African principles. If there's conflict in the group, we go to the principles. If we have to make a decision, we go to the principles. So this is one of the major nucleus that really allowed this program to work, is to have ways of engagement, ways of communication, ways of viewing holistic health, ways of looking at individual health and community health. Next slide, please. So we're not going to show this video, but this is a video that you'll get when you get the slides. Next slide, please. Some of the evaluation we came up with, and when we say we, it was actually the community that came up with their own list of do's and don'ts. Some of the don'ts is don't be judgmental. That was one of the major ones that came up with all the 4 sites when we were doing evaluation. Some of the do's is take care of yourself. You can't give what you don't have. If you don't have peace within you, you can't give peace. If you don't have patience, you can't give patience. So that's one of the major things that the community said. Our link workers or connectors, they have to take care of themselves first. Next slide, please. We're almost done. Here's some stats that came up in our first year evaluation. And I just want to highlight that 88% of the social prescriptions were food prescriptions. So how can one dance, drum, move, walk, hike if they don't even have enough nutrients to help their lymphatic system, their muscular system, or even have the chemicals going through their brain to think clearly and have happy hormones? So one of our major social prescriptions is the food prescriptions. Next slide, please. What is working? So what has been working are the different forms of food prescriptions, whether food groups or giving food vouchers. These are some of the things that have been working that all the sites have reported. Next slide, please. What makes Black focused social prescribing empowering? The huge feedback is the sense of connection. What we've noticed is even our allies who don't identify as Black, they don't want to leave our programs. They just want to learn and be a part of it. So it's safe for everybody. It's safe for all bodies. And that's what's empowering about this program is Black focused is actually human focused. Next slide, please. If you want to go fast, go alone. If you want to go far, go together. This is an African proverb. Next slide, please. And we are complete, I believe. Questions, comments, observations, concerns, put them in the chat. Love and joy. Namaste. Thank you, Ivory, for this opportunity.
Thank you so much. That was wonderful, dynamic, zesty as always. So thank you so much. And you know what I really heard from your presentation is the importance that you went to the community, not with the answers, but with questions. What was important to the community that you were serving? What were the values that would form the framework for you to serve them? And I think that's something that we really need to listen to and pay attention to in this work, is the importance of really entering this work with humility and listening to the community. So thank you for illustrating that. We now have time for another quick testimonial video. Anjeza started as a participant in the Community as Medicine model, which is led by Open Source Wellness. It was prescribed to her by her primary care physician at her local federally qualified health center in Alameda County, California. She subsequently became a peer leader, a coach trainee, and is now completing her practicum training hours to be a board certified health and wellness coach. So we'll hear from her now.
Everyone, thank you so much for giving me this opportunity to talk about my journey at Community as Medicine model led by Open Source Wellness. My journey started as a participant that my doctor referred me to this program, and I wasn't familiar and I didn't know how it works, and my goal was lose weight, and also I was like I was afraid of talking in front of people due to the language barrier that I have, um, and as an immigrant, navigating all the systems, all of those were very hard for me. And the first time when I received the call from my coach, I felt different, and I felt safe, supported, and non-judgmental. And going forward, when I joined the group, and group works like started by icebreaker, and then movement, nourish topic, and coaching group, which where we set goals there. I wasn't like feeling comfortable even to be in a camera and answer the icebreaker. Didn't have any idea how to answer that. Day by day, I got familiar with all of those, and I was really enjoying the program. And I incorporate movement in my daily life, and I feel good talking and sharing, participating in different parts of the program. And then when the program, as a participant, it was my time to end the program. I really felt not good to leave the program, and that I became a peer leader, helping others as a peer, as an experience that I had there. And then another like chance to be a camp student and a practicum trainee, where I learned a lot of skills about how to be a coach in different areas, and that's amazing experience that I had, and a practicum training, now working toward my hours to be an certified health and wellness coach. And that was all about my journey, which I really enjoyed and learned a lot of things. And thank you so much for the support and all of those. I appreciate it.
Wonderful. What a testimony, from being scared to be on camera on day one to now having a video recording that's shared with all of you, over 117 people. That's quite a testimony. Thank you all for sticking in with us. We have one more speaker, Rachel Chen. She's a first-year medical student at Harvard Medical School. And as an undergraduate, she co-founded the Harvard Undergraduate Initiative for Social Prescribing and helped launch the U.S. Social Prescribing Student Collective to support student advocates in building resilient communities through holistic care. In exploring how the UK model can be adapted to the US context, she published a long-form article in Time magazine highlighting the US social prescribing movement and its pioneers. Big shout out to her for that. She creates the infrastructure and evaluation framework for a pilot program at the Cleveland Clinic and serves as a visiting collaborator at the National Academy for Social Prescribing. Thank you, Rachel, for joining us today.
Thank you so much for having me and for that entirely too flattering introduction. Hi, I am a first-year medical student. I am one of many students who care about social prescribing and one of the co-founders of the U.S. Social Prescribing Student Collective. So I just want to start by saying that I got into social prescribing a few years ago because of a very similar webinar I attended given by Bogdan, who you've now met. So I think I am living proof that it only takes one good conversation, one good talk to really hook someone and feel motivated to do something about this. Slide, please. So why does social prescribing matter to me as a student, as a young person? I think when I heard about social prescribing back in 2020, I had a lot of ideas about what I thought medical care should look like and what social care should look like. And they revolved around these big principles: person-centered care, personalized care, holistic, social determinants of health, co-creation, and accompaniment. And these were all really important to me in the abstract, but I did not know what they looked like. I only knew what our current medical system does, which is not delivering on many of these fronts. And frankly, as a pre-medical student or as an aspiring physician, not delivering on the type of system I want to practice within. So when social prescribing came along and I attended this talk and heard from Bogdan, I saw in social prescribing a way to bridge principles with practice. Maybe not the model, we're always iterating, we're always learning, but a model that actually embodies co-creation and partnership with patients and partnership with communities. A model to actually address social determinants of health using social solutions. We know that so many of these things will not be solved with pills and procedures. And we know that there's this neglected toolkit we have that we are all enjoying all the time and all reap the benefits of, and yet we don't rely on them in the medical care system. And kind of at a systemic level, I think social prescribing is really beautiful because it represents a model that truly encourages and empowers communities to have resilience and to lean on each other instead of turning toward the medical system, which is, again, ill-equipped to do all of these things at once. Slide, please. So something that I really loved about joining this movement is that the idea of co-creation reaches really far beyond just the clinical interaction. Everyday people and students like me who had no skill sets whatsoever got to be part of the movement and to sit in the driver's seat and to really contribute where we thought was important. And so I came back from a brief internship with Bogdan at the National Academy for Social Prescribing, ready and raring to go, very enthusiastic and excited to try and make social prescribing happen in the States, but having very little understanding of what the barriers and challenges were in our very different medical system in the States. So my very first project was to just take advantage of a science journalism class I was taking at the time to interview some of the earliest implementers and advocates. So I got to talk to Dan Morse. This is how I met Alan. This is how I got connected with Mass Cultural Council. And I had the opportunity to sit with them and say, well, I'm hearing this critic. I'm hearing this idea. I'm hearing there's a lack of evidence. What do you think about all of these things? And what are we doing as a movement right now to fix that? Or how are we thinking about that? And the end product not only helped me understand the barriers and challenges a lot more, it was so rich and full of exciting stories and material that Time magazine picked it up. And in that way, I was able to document and contribute to the movement by crystallizing a particular pivotal and exciting moment in time for the social prescribing movement. It is now long outdated, so if you check out the article, maybe you can reminisce on what the baby fledgling movement looked like before we had all of these amazing pilots around the country. But it was a really special moment that I got to be part of in a small way. In the process of writing this article, I was also connected with Dr. Ardashir Hashmi at the Cleveland Clinic. So he is the chair of the geriatric division and was already doing social prescribing for years and years, informally. And he expressed this interest to formalize it. And I said, I've got nothing going on next summer. And from that single conversation grew this wonderful relationship where I got to go to Cleveland Clinic and help build out what a pilot could look like more formally. So again, this was another exercise of putting principles to practice. What does it actually look like to be on calls with community partners and make offers and figure out where communication is falling apart, figure out what each of us needs from each other? What does it actually look like to integrate social prescribing into a very busy clinical workflow where every person is already stretched pretty much to their limit? What does it look like to try and evaluate a pilot in a way that is rigorous enough that the evidence base would accept it, and yet still not so rigid that, you know, current metrics aren't picking up everything that is so important and all of the outcomes that are so important to our patients. And so that was really wonderful. And another place where students like myself have gotten to really contribute to the movement. Slide, please. Maybe one of the best and most rewarding things that I got to do as a student was work with other students. And so that started at Harvard College, where I was. I got together with some of my closest friends, other people who really cared about social determinants of health and really cared about social prescribing. And we formed a student interest group where we put on events like speaker series. And here's an image from when Bogdan came to visit and give this awesome talk to so many students. Room was packed. And I think that's something I wanted to highlight is there's something very special about my generation, which is that social prescribing is not radical. It's not surprising. It's common sense. It's intuitive. Everybody in that room already knew the importance of social prescribing, already cared about the principles of it. And so all we have to do was get us all in a room together and redirect that energy. Slide, please. So that's what we did. We built out this internship program where we matched students based on their interests to different implementers at the time who were willing to take on students and let us get our hands dirty and let us be part of projects. And so I just wanted to highlight a few of the cool things that we've gotten to do. Our student Manasa worked with Mass Cultural Council on their big pilot evaluation, and that was first published in a white paper and then later became a PubMed article that contributes to the evidence base and is cited. Our student Josh worked with the amazing Epi Arts Lab and at UF to create the field guide for arts on prescription. And also he was so inspired by all these experiences that he wrote his senior research thesis on Project Connection, another amazing force in social prescribing out in Utah. And I know he visited just a few months ago and it blew his mind. He had so much fun. We've also gotten to help plan and staff conferences at Columbia up top and at Harvard on the bottom. So we've really gotten to be we've been in the room where it happens, and we've gotten to arrange the furniture in the room where it happens. We get to design what it looks like to be in the room where it happens. So that has been really, really special. What we started to think after a while of this local organization is, if so many students around us at Harvard care, how many care in Boston? How about in Massachusetts? How about in the United States? So we got it in our heads that we would love to start a national collective and see who else around the states cares about this. Slide, please. In March 2023, we launched the US Social Prescribing Student Collective, with so much tremendous help from our colleagues in the UK and in Canada who have built out very robust and incredible programs for students to get involved. And our launch program reached 250 people from over 50 institutions. We imagined a kind of chapter design with built-in supports, built-in meetings, like-minded students getting to work together on projects that they cared about, co-creating projects that really matter to them locally and nationally. And we created this playbook to guide students who are interested in social prescribing to then start seeding the movement where they were. Unfortunately, the national collective is a bit less active now, and I'd like to believe it's because people are focusing their efforts more locally. But I wanted to reassure people that the energy is there, the resources are there, people really do care. So if you are a student and you want to get involved, please message me. I'd be happy to talk to you. And there are so many other students who really care about social prescribing and are doing stuff about it. Slide, please. I just want to end on this invitation to co-creation because every person in this picture brought in such a different skill set. Me and Taya were historians in undergrad. Sonia was a writer. She majored in English. She wrote our manifesto. Maddie is a stem cell biologist. She is a STEM person through and through, and yet she still really cares about the delivery of the medicine she creates. And Chudi had already done food prescriptions in his life and then wrote a really mean grant for us to be able to become a student org. And what I'm trying to say here is that if you think you don't have anything to bring to the table, you're wrong. And we need people like you. We need your skill set to build this from an interdisciplinary perspective. And in fact, if you're a young person and if you're a student, not only do you have something to bring to the table, you deserve to be in the driver's seat. We are the people who will inherit these global problems, inherit this planet this health system, this economy. And so if you care about any of these things and you think social prescribing could be an answer for that, as I do, step up, because we should be in the position where we can design the systems we want to live in. Thank you so much for listening, and I'll be around for questions.
Thank you so much, Rachel. I think that people often underestimate the power of passion, and everyone on this panel and everyone in this room is here because of a passion for this type of healing. No one's here getting CEUs at this point, right? Maybe in the future. But, you know, we're here because we have a passion for something better for ourselves, for our communities, and for our healthcare systems. So you just so eloquently ended that on that point. So thank you. I want to give a big thank you to all of our speakers. What a stellar lineup. I feel so privileged that we had such a stellar lineup for today. Thank you for all of your wonderful presentations. And we do have just a couple minutes for Q&A. I did see something just pop up into the chat a moment ago. So I'm going to pull that up, and then we will get you out of here right on time. And I saw a question that I thought was a good one for Hathor-Ra. I believe it was asking about, yes, here we go. How does the link worker, or other term, right, community connector, what have you, match the person with social activities that fit their particular interests and circumstances? Such a great question. Do you want to speak to that first?
That's a great question. So we actually created an intake process that's African centered. So it's similar to the Indigenous Medicine Wheel, where we look at all aspects of health. So through that conversation, we know what the spiritual health is, emotional health, things like that. And then we connect them to other internal programs or other projects or other agencies that are either our allies or also Black focused, like they've been doing it for years. So we actually developed like a whole intake process that will capture that holistic health and that holistic approach.
Wonderful. Thank you so much. So very patient driven, and also can be a diverse set of activities and supports, it sounds like. Wonderful. Thank you. And the same person just asked a follow-up. The systems that Dr. Allen, Dr. Bogdan are working in, do you have anything you want to say in response to that question, to how people are matched in your systems?
I can maybe chip in, and then Alan, I can pass on to you. I think it's an amazing question, and Rachel, when she visited us in England, we emphasized this so much in terms of the importance of one size does not fit all. It has to be true co-design and co-creation. And I think Rachel put this in her presentation, Alan put it in his. It's the idea of focusing on not what's the matter with the individual, but what is it that really matters to them. And the idea that through sitting down, building a report, hearing the real need of that individual, you dig deep and find out what's at the root core of what that individual cares for and matters to them. In 10 minutes in the emergency department, I may not have time to do that, sadly, but in an hour with the link worker, sitting down hour after hour and building that report slowly over time, you will get to build trust, you will get to understand more about that individual, and then you have this menu of activities that is based, of course, on the passions and the needs of that particular person. So from my end, that is a step that must not be skipped. Otherwise, it's pure signposting. So that's what differentiates, in my opinion, true social prescribing from mere signposting. The fact that I tell people to stop smoking, stop drinking, go exercising, go gardening means nothing, because we know we've done this for many years and we know it doesn't work. But what's special about social prescribing is that element of co-design, co-creation, and focusing on what really matters to them.
Wonderful. Thank you so much. Alan, anything to add to that?
No, we're at the early part of our program where I'm now working at Kaiser. And so we're just designing it, but we are very thankful to all these other systems like the ones in the UK and Canada and Australia that have been figuring out how these systems work. I think the challenge will be how to figure out who is the community health worker or social worker, or how does that link worker happen in the United States, as we are a complicated system.
Yes.
I'm going to go
wonderful.
ahead and transition and thank everybody for being here today. We've heard a lot of amazing sets of perspectives. Bogdan is a successful driver of social prescribing in the UK. We heard about our equity-based program with Hathor in Canada. We get to see the next generation with Rachel, undergrads, medical students. I mean, maybe that's where we need to really start and like think about the next generation and what medicine looks like. But I hope that you've seen that this is something that we can do and something that we need to do in this country. And I hope that you will join us and help make that happen.
Wonderful. I also just want to give a quick recognition. You know, everything that happens on screen on a webinar is because of people behind the screen, and their role is just as vital as ours, who you saw on camera. So I just want to take a moment to acknowledge the webinar team. So please thank me please join me, excuse me, in thanking Jennifer Kuo, who made this so seamless, the smoothest webinar I may have ever been on today. Josh Hill, Purvi Shah, Camila Ronderos, Kelly Corcoran, John Soleil, Jackie Knight, and Louise Woe. Thank you for all the behind the scenes. We see you. And thank you everyone for being here.
Thank you all.